Okay, looks like the recording has started. Thank you, Carissa. Welcome everybody to the Assembly Health Policy Committee meeting. It is Wednesday, December 2nd, 2020. We are noticed from 10 a.m. to 11 a.m. And I am Suzanne LaFrance. I co-chair this committee with Assembly Member Meg Zeletel. We'll go ahead and start with the roll call. Ms. Sleppy, would you go ahead, please?
Yes, I can. Ms. LaFrance?
Here.
Ms. Zeletel?
Here.
Ms. Allard?
Here.
Mr. Constant?
Here.
Mr. Dunbar?
Here.
And Mr. Rivera? Okay, thank you.
Thank you, Ms. Sleppy. Okay, so the agenda is posted online, and if you go to muni.org, if folks could please mute their phones. Thank you. If you go to muni.org, click on Assembly, and on the left, Committees, and then Health Policy Committee, the agenda is posted there. So we have two items on the agenda for today under new business. We'll start with an update from the AHD, Anchorage Health Department, and then we'll have a discussion of the COVID-19 dashboard metrics. We have the two standing items, committee legislative and budget priorities on the agenda, but I don't expect we'll have much of a discussion around those since the budget has been passed. And then we'll save some room at the end for audience participation. So we'll go ahead and get started with the update from Director Heather Harris at the Anchorage Health Department. Ms. Harris?
Yes, thank you so much for the opportunity to share a little bit about what's going on here at the Anchorage Health Department. First, I'll just share a little bit about what's happening in administration. So first, we have been coordinating some facility improvements here at the health department. We had some issues with our front door, and so when you have the opportunity to visit the department, you will notice that we have a new front door, and that got replaced. And grants and contracts, we've been working on a strategic national stockpile agreement with the Anchorage Regional Hospital, or Alaska Regional Hospital, excuse me, and several other contracts as well. In animal control, we're working through public comments received on the proposed revisions around Title 17, which addresses animals in public places. And they are working on those changes and proposed revisions, but no changes have been decided upon at this time. But you might see some information about that in the future. Around emergency preparedness, we have been continuing to work on the COVID-19 pandemic, and specifically in our emergency preparedness program, working on coordination with Visit Health to provide COVID testing with assisted living facilities, some of our municipal operated shelters and other shelters within the Anchorage area. In addition to providing additional pop-up testing sites, which are now in operation to meet demand and provide more accessibility for those throughout the municipality. We are continuing to work on contact tracing and monitoring and filling requests right now for additional capacity around contact tracing and working on an invitation to bid process to expand that capacity. We've expanded shelter options and capacity over the last month. The Fairview Rec Center has an opportunity for an additional 50 persons experiencing homelessness, and working with the Emergency Operations Center on that as well. And we're starting to really dive into the vaccination distribution planning and anticipation for a phased approach in the distribution of the vaccine, working with the Emergency Operations Center and with the state on what that looks like specifically here in the municipality. Around our Human Services Division, as we look at childcare licensing, we are continuing to distribute the $10 million for licensed facilities. And as of the beginning of October anyways, we were about halfway through the distribution of those funds. We are working on continuing to license childcare facilities. Specifically wanted to highlight the Campfire program, which is in partnership with the Anchorage School District, to provide learning pods where providers are trained and deliver computer technical assistance for school support at Title I schools specifically. Our Community Safety and Development program has been working on some of the recent notification that we'll have our third and final CDBG CV funds in the amount of just under about $2 million. And these funds will eventually need to be introduced and approved by the Assembly. And we are in the current process of determining highest need and recommendations for the use of those funds. It's about how to determine that highest need. Please feel free to share those thoughts with me. I'd love to talk with you about that. Our senior and emergency outreach is very focused on providing services and supports through the pandemic, and several households continue to receive utility assistance, and we're working on continuing to distribute ESG funds through the ADRC as well. As we look at sheltering, I shared a little bit already about increased capacity at the Fairview Rec Center, but also just really working on decompressing the Sullivan and doing that in the most strategic way as well, and working with community partners on that as well. As we look at the Public Health Division, community health nursing continues to be very focused on COVID. A large percentage of our clinic staff is still leveraged for the COVID response and will continue to be for several months still. Even though that's the case, the reproductive health clinic, TB clinic, and HIV prevention continues to do work, specifically around reproductive health. Syphilis cases are quite high right now, and we're focused on treatment for them and their partners. As we look at environmental health, we continue to reach out to businesses throughout the community and provide additional COVID business protocols and best practices while helping them to respond to COVID positive employees and potential customers as well. We continue to do the virtual inspections that were developed earlier in the pandemic, and that has been quite successful, and I've heard really great things from the community and some of those businesses that have received those virtual inspections, and just sharing that has been a very helpful process for them. Our Women, Infant, and Children program continues to have a pretty high caseload and just serving a lot of participants. They are currently at 4,500 participants in October. And we were able to provide face coverings as well for many of our childcare facilities involved in the program. SNAP Ed, we continue to work and distribute and outreach for that program. We've developed a healthy retail recognition program aimed at making healthier choices more visible and accessible in small grocery and convenience store locations and specific census tracts to get that information out. And then just as far as our calendar for the rest of December, we anticipate a hand commission meeting. The Senior Citizen Advisory Commission should be meeting, the Anchorage Women's Commission meeting, and the Animal Control Advisory Board will all be meeting in the month of December. And that's the end of my report.
Thank you, Ms. Harris. You have a lot going on with the health department for sure. There's a question for you from Mr. Dunbar.
Thank you, Madam Chair. Ms. Harris, I was wondering if you could give us a little more details on the vaccine distribution program as it's getting set up, and in particular, can you talk a little bit about prioritization and in particular on that, I'm interested to know where teachers fall and how that might relate to plans to reopen some in-person schooling in January.
Great question, Assemblymember Dunbar through the chair. So the vaccine distribution, it is moving quickly, and there are a lot of details to work through. Although I think the EOC likes to say that they are trying to plan and to avoid. So even though we may not have details around all of kind of the distribution, we are working diligently to plan for whatever scenario might come our way. The distribution will go in phases. It's in a two-phased approach. Phase 1 is also being broken down further into a phase A and a phase B. Specifically, phase A is very focused around healthcare providers and potentially first responders and those that have the potential of being exposed to COVID-19. We're getting more details as the hours and days go by. And so as far as where teachers land in that prioritization, I'm not positive at this point in time where they are in that, but I do know that those that receive it first will really be those in the healthcare profession and focused on providing that medical service to our community and specifically to those with COVID. But I'm happy to share additional information as we get that and can send that through the Health Policy Committee probably as more details are available. The other thing I'd say, sorry, circle back to your comment about teachers and the potential of that helping and supporting the start of in-person school in January. At this point, it does not sound like that will be in that quick of a turnaround to impact a school start in January, given that preliminary dates really looked at probably December 15th. Now we're really hearing maybe probably closer to the end of December before we actually receive our first vaccines. And again, those will go to those healthcare providers. So it will not reach teachers by beginning of January to impact that anyways.
And Mr. Dunbar, you have a follow-up?
Yeah, thank you very much, Ms. Harris, for all of that. I guess I would put a plug in for insofar as the Muni has any influence on this decision, that we try to add our voice to those that do want to prioritize teachers, not necessarily in front of healthcare providers, of course, but there are a few professions that are going to have that kind of sustained indoor interaction with a wide variety of folks, where you're sitting for hours at a time with a group of, 20 people or 30 people. And I know that a lot of folks in the community really want our schools to reopen. It has a huge rippling impact on, I shouldn't say our schools to reopen, our buildings to reopen, because it has such a huge rippling impact on our society. So, maybe it won't be in January, maybe they'll have to push it by a couple weeks, but if vaccines could help us push it by a couple weeks instead of a couple months, that would have a real impact. So again, if there's any way for us to sort of join those voices, I would really appreciate it. Thank you.
Absolutely.
Thank you, Mr. Dunbar. Sorry, go ahead, Ms. Harris.
No, you're totally fine. Yep, take noted, and I will incorporate that into the conversation as we move forward. The other thing I think is important to remember is that what we're seeing right now with the vaccines is that it is likely to be a two-shot series, and so it's going. There's going to be a lag in when the vaccine is then effective. So there's just some timing, but I will take those considerations forward as well. Thank you.
Thank you, Ms. Harris. Do any other members have questions on this part of the agenda? Okay, we'll go ahead and move on to item 3B, discussion of the COVID-19 dashboard metrics. And in this part of the conversation, we want to look at analyzed by the health department. What does it tell us about the status of the community risk level? And we talked a little bit already about the vaccination rollout plan, and Ms. Harris talked also or mentioned contact tracing and filling positions. We may also discuss in greater detail here the status of testing. And Ms. Harris, I don't know if it'll be you or Dr. Johnston who's going to walk us through this part.
Yep, Dr. Johnston is available and will walk us through dashboards
Okay.
and decisions. Thank you.
Do you have a presentation, or do you want to just put it up on your screen?
Right, I was hoping to share it and actually walk through the metrics online.
Great.
Can you see my screen?
Yes, I can
Okay.
anyway.
Great. So as many of you are probably aware, the municipality has this COVID response page. And for those of you who can't see the screen, I find the easiest way to get to it is to go to the muni.org page, and then up at the top it says there's a big button that says COVID-19 updates. And if you click on that, it takes you to this COVID response page. As you scroll down on that page, you'll see a whole bunch of different categories of information, one of which is data that I'll come back to shortly. Then as you scroll down further, there's a graph of cases by COVID cases by onset date with a 14-day rolling average. Go down a little bit further, there's a snapshot of the most recent day's case numbers. And then if you keep scrolling down, you get to the Mayor's COVID roadmap metrics. And this is what we call the stoplight dashboard. It's got 3 categories: epidemiology, healthcare capacity, and public health capacity. We have 2 metrics under epidemiology and 3 under each of the other 2 categories. And these can be set to green, yellow, or red. And these metrics were actually decided on last spring. I was not in this position at that time. I had a little bit of visibility into the process, but was not intimately involved in it. But what I want to do is go through what all of the metrics are here, talk a little bit about how we make the decision as to whether it would be a green, a yellow, or a red, and then talk a little bit about how that helps inform decisions about emergency orders and restrictions. I also want to point out that to get to the more detailed metrics for this, if you go down in the left-hand corner, it says Detailed Metrics Dashboard, and you can click on that. That will take you to this page, which has a whole bunch of different graphs on it. And there are a number of different places that I go to look at the data for these different categories. I'll start with epidemiology. And in epidemiology, we're really focusing on the daily new case counts and the daily hospitalizations. So if you go to this first graph here, and I'm just going to expand it. If you click in the upper right-hand corner, you can expand that. This is showing by onset date, which would be the date, theoretically, it would be the date when somebody first was infected. So if we had symptoms, you would count back a couple days from that. In reality, this is usually now the date that you were tested. And particularly for people who are asymptomatic, which is up to about 40% of the cases, we don't really know when the infection starts, so we use the date of the test. And we look, switch over here. In order to get a more stable picture of what's going on with onset, we look at the 14-day average. We can also look at the 7-day average, and that's really just what it sounds like. We look at the 14 days prior to the date we're reporting it and look at the average number of cases over those 14 days. This smooths out the variability. When you look at the chart, you can see these individual lines. Those are the actual number of new confirmed positive cases based on the onset or test date for each day. And you can see, we have a lot of variability here. for some reason on November 16th, which was a Monday, and we tend to get a lot of testing on Monday, we had an incredibly high percentage of those tests test positive. And so we had 780 new cases by onset on that date. But that's not where we are on the average. So this line here shows the average. And what we look at in terms of setting this metric is both the level and whether it's increasing or decreasing. Now, these metrics were first developed back in the spring, and you look over to the left, we were very lucky at that point. Lucky, and also had done a lot of work with putting prevention efforts in place, that our average number of new cases per day was very low. Back in May, we were averaging 1 case a day. But then in May, it started to go up. So we would have this set to green if we had an average of 5 or fewer cases per day and we were remaining relatively flat. As we start to go up, then we start to think, well, there's something to be concerned about. And so we move into a yellow zone if we're seeing a continual upward trend in this 14-day average. Or if we plateau, but we plateau at a level that's higher than we would like to be at. So that would put us into the yellow. And then as we start to go up from that moderate level, you can see here, let's say starting in September, up through the middle of November, we had a pretty steady, steep incline, already starting from a level that's much higher than we would want to be. I also want to point out that as the case counts have gotten so high, the state section of epidemiology, which does the entry of the cases based on the lab results that they get, and then they do some processing to make sure that there aren't duplicates, they have gotten behind on the entry. So as we see a decline here in this moving average in recent days, I suspect, and what State Epi is saying, is that this decline has more to do with the backlog in cases than it does with a real decline. But we won't know for a little bit longer as those cases get filled in. And I'm just going to jump over to the state website for a minute to help you understand a little bit about the relationship between the onset date and the report date. This is that same graph of cases by onset date, but if I switch it to report date, you can see that the cases move to the right, because that's the delay between when people actually got tested and when it gets entered into the system. So this would be the numbers that you see reported each day, but then they get moved back to when the onset was. And I want to walk through very briefly the time frame so you can understand the time lags that we'll see in a lot of these different measures. If someone's exposed on day 1, they would become infectious somewhere on average between day 2 and up to day 14. But in general, let's say they would become infectious on day 3 and maybe start having symptoms on day 5. Day 6, if they're on top of things, would go get tested, maybe even up to day 8, because often it's a week before symptoms may start. And then it takes a number of days for the test results to get back. And the average on that has actually improved a little bit recently. So let's say it takes 2 days for them to get their report back. So that would be day 8. But then it may take another couple of days for State Epi to get it into the website. So now let's say we're at day 10 or even day 12. So from the exposure to when it gets reported and reflected in the dashboards, it's almost 2 weeks. And that's why frequently when somebody asks me, so can you tell if the change in restrictions is having an effect? Unfortunately, for the first 2 weeks, I really can't say much of anything. And then you still need a week or 2 after that to see, get a stable estimate of what the effect is. So that's why it really takes almost a month before I feel comfortable saying if we've had a change. So again, under epidemiology, we look at case trends and we also look at hospitalizations. And I'm going to go. And just so if people are trying to follow on their own, to get to the hospitalizations chart that I want to look at, I go up to the data option on this Muni COVID response page, and that takes me to another set of data charts. And one of those that's very useful, up at the top, there's this COVID cases by report date, and it also has deaths and hospitalizations. So we look at deaths by month and then new hospitalizations. This chart of the deaths, again, you can see it unfortunately is also increasing. What you'll see is most of these charts all have a similar shape to them. They may have a different magnitude because fortunately we have many fewer deaths than cases, and they may be shifted a little bit in time because hospitalizations and deaths lag from the beginning of the cases. It takes some time after someone, becomes infected to be sick enough to be hospitalized, and then sometime after that before they would pass away if they didn't survive.
Dr. Johnston,
Yes.
we have a question for you from Ms. Zelatel.
Thank you, Madam Chair. So I'm curious, these tend to link up with the color-coded stoplight, I guess is what I'll call them, metrics. Is there a way? So this is more of just like, maybe it's a question that has to go back. That's up for the tech people or the IT people. But when you are using a particular stoplight and it really relies on this additional data, that when someone clicks that stoplight, that they could get sent to this data, because right now, when I click on a stoplight to learn more, I just get a bigger version of the stoplight with no additional information. So I am already not lost, but I find it hard to track how to get through all of these different data sets as they relate back to the main metric. I hope
Yes,
that's clear.
So I can give you two things on that. One is, yes, I can talk to the GIS folks and see if that is probably something that they could do. And then the other piece is, as I go back, so here if you're at the stoplight, if you click on this detailed metrics, most of what you need is related on this page. I say most of because unfortunately, and I don't always look here because there are other places that I tend to look, but they pulled them all together here. The hospitalizations one is not on this page, but almost everything else that we use for those stoplights is on this page. So
Sure. May I do a quick follow-up, Madam Chair?
Yes, please go ahead.
Thanks. Yeah, I guess what I'm trying to do is on these particular, so you've got cases by onset date, hospitalization trends, is how do they link to these, yes, the ones you have up here or the ones on the more detailed metrics dashboard? I'm having a hard time knowing exactly what goes into each of these things to point back to the data. I'm trying to complete the loop, I guess. Is
right. So the first one, the case trends, is from this cases by onset date.
Okay, so that would be good, yeah, if they could link up together, because we get constituent concerns about a particular metric, and I don't always know enough depth of detail to get them to where they or be able to help them in their questions. So
right,
okay.
And I think they could probably do that fairly easily. I do want to say one of my favorite phrases that there's an art and a science to epidemiology and statistics. So we have guidelines tied to one main metric, but I do tend to look at a number of things just to make sure that you've got consistency before we would make a change. But particularly for the cases, it's very much this cases by onset date. And then the second one, the hospitalization trends, is this hospitalizations by hospitalization date. So I can ask the GIS group if they could just change that link. So rather than having it show up as a bigger stoplight, which I realize is very frustrating, that we can give you a link to like this chart.
Awesome. Thank you so much.
Sure. And so this is similar to, I'm sorry, are there any more questions?
Thank you, Dr. Johnston. I just wanted to note that Ms. Allard had a question about your contact information, which is in the chat. And actually, just for the record, would you state your name and your title, just so we have that?
Sure. Dr. Janet Johnston, and I'm epidemiologist with the Anchorage Health Department. And I have a PhD and MPH, Master of Public Health in Epidemiology.
Thank you, Dr. Johnston.
Okay, so let's continue with the hospitalizations. And this is a similar way of setting it between the green, yellow, and red, that if we'd like to be seeing fewer than 3 new hospitalizations per day, and either at a flat or decreasing rate. And that would have us in the green. A slight increase at a higher level, we'd go into the yellow. And then as we get to these higher levels, a sustained higher level, that's what puts us into the red. And you can see here, as we get over to the right in November, we're at a higher sustained level than we were over the summer. And then over the summer, we were at a higher sustained level than we were in the spring. And this is why we're very concerned, because as we get continuing new hospitalizations at this higher rate and people stay in the hospital, it's really starting to stress the healthcare system. So those are the epidemiology measures. The healthcare capacity measures are really focused on the ability to handle an anticipated surge, being able to protect workers. So that's looking at the supply of personal protective equipment and the test capacity. So looking here, the thing people key on the most is the number of available adult ICU beds. And so what we get is a report of that. We focus on the 3 acute care hospitals in Anchorage, Providence, Alaska Regional, and the Native Medical Center. And then on a daily basis, they report out how many possible staffed adult ICU beds they have. Yesterday, that was reported as 65. And then how many of those are filled. So there were 59. That would mean that we had 6 available beds. Which again is a little bit concerning if we were to have a major surge, particularly because Anchorage gets cases both from the Anchorage area and cases that may come in from more rural parts of the state, either because the locations don't have their own ICUs or the ICUs are filled. So there's that measure that we look at. Early on, and we do watch ventilator capacity, but what we've found is that ventilator capacity, that's not as much of an issue. We have a lot of ventilators in the state. A slight concern with that would be more the staffing, because we need to have the respiratory therapists who can staff the ventilators. But at this point, that hasn't been the major concern. And then I will just show you that we have additional hospital data. If you go to that data page, you can see in more detail the number of patients we have hospitalized on any given day. So right now there are 93 confirmed COVID cases hospitalized in Anchorage and 149 across the state. And then we have 7 PUIs, persons under investigation, who we suspect have COVID, but their test results have not come back yet. And then again, related to this surge, we have more detail on the available adult ICU beds. So we've got the 18 have COVID patients in them right now. An additional 41 have non-COVID patients. And then there are the 6 available that I was just talking about. And you can see, again, how many COVID patients are on ventilators. We have 20 Anchorage COVID patients on ventilators. And we can see the percentage of emergency room visits that are related to COVID. And this is also something that has been increasing slowly, but also steadily over recent weeks. And then this shows the current number of hospitalized patients. So the first one I looked at was the number of new hospitalizations each day. That gives us an indication of how the epidemic is growing, similar to the new case counts. But then when we look at healthcare capacity, we're interested in how many hospital beds, and then how many of those beds that need more advanced staffing, like the ICU beds, are being taken up with COVID patients. And that's what this chart is showing. Again, very similar to what we saw before, very low in the spring, higher in the summer. At that point, we thought that was, really bad, and now it's gotten significantly worse. And so you can see this much higher level of hospitalized patients at this point. Then, as I said, we need to be sure that we can protect our healthcare workers with the personal protective equipment. This is less of a concern than it was early in the pandemic. When the pandemic started, there were severe shortages of PPE across the country, but it is still something that we're watching. And so again, on this page of the roadmap detailed measures, we have a chart here that gives an indication of the available PPE, what's on hand at the different hospitals. And this is pulled together from a bunch of different surveys of the hospitals. We also watch, in terms of setting the light, it's also based on what we're hearing from the EOC. They report each week on how many requests they're getting, what they're able to fill. And in general, the situation has been, for recent weeks, that the smaller providers still need to get some PPE from the Emergency Operations Center, but in general, we are able to supply them with what they need. This is becoming a little bit, well, actually not so much the PPE, but there are some concerns related to vaccine, as there's some overlap in supplies needed for testing and for vaccination, which is starting to make like needle supplies tighter across the country. So we will be watching that.
Dr. Johnston?
Yes.
Ms. Zalatil has a question for you about the PPE chart.
Okay.
Thank you, Madam Chair. So I don't understand this chart. I've looked at it a few times. So let's take the 31 plus days, 29.17%. I don't know what that means. Does that mean that 29.17% of our hospitals have 31 plus days of PPE?
Yeah, and so, I will admit that when I set this, I rely much more on what the EOC is telling us. But what happens is there's this federal reporting system that the hospitals report both how many patients they've got, ICU beds available, and then they report on a very large category of PPE. And so this is a combination of the number of hospitals, but also the averaging across all the different PPE categories. So you've got masks, and then you've got all kinds of different masks, and you've got gloves and booties and the whole range of PPE that's needed. So this is trying to give it a very high level, an impression of how well we're doing. But the detail is overwhelming even for me. Just for comparison, you can see with the state, there are, for at least some category and some hospitals, they are out of PPE. So one of the things that we look for is, is there any red, which fortunately in Anchorage there isn't, and then how big is that red slot versus also this orange, which is saying 4 to 6 days, which here is 25%. Again, this is just giving a very rough idea. And so that's why we also really rely on the PPE information from the EOC, because they're actually getting the requests and giving out PPE.
If I may, Madam Chair, is that PPE percentage then reflects not only then that that number of hospitals, but it's the actual availability of certain types of PPE as well. So it's like that percentage is a multi-function percentage. It reflects a lot of different data points.
Yes.
Okay. Yeah. That chart is really confusing. And it's really hard to see how that translates to the yellow stoplight metric on the public stoplight dashboard, because that chart has 4 different colors in it and we have yellow here. I don't know if there's an easier way. I'm just, I'm confused, and I've tried to dive in as deep as I can. So I just want to provide that feedback.
And I agree. Again, I wasn't involved in all the details of pulling this together, so I'm not sure the intent at that point. But at this point, when we make changes in these stoplights, it is very much a looking at the exact data points that we have, but then also, particularly for the PPE, delving into conversations with the EOC to understand what they're seeing on the ground.
Okay, thanks.
Sure. And then the third category is the testing. And here we're looking at a combination of test capacity, how quickly tests can be turned around, and then also the percent of positive tests that we're seeing. The issue with the percent positivity, which people focus, you probably have heard a lot about, is that the higher that number is, it's an indication that we're probably not finding all of the cases. So if we can keep the percent of tests done that come back positive to under 5%, then we feel confident that we're testing enough people to really be finding most of the cases. But as the percent of tests that are positive goes up, it's an indication that there's a lot more virus out in the community and that we are probably not finding all of those cases. And so for this one, I'm going to switch over, sorry. To the state website, because I find this graph a little bit easier to explain on that positivity. Put this up here. And again, with this one, you'll see that actually at the beginning of the pandemic, we were much higher. So in terms of number of cases and hospitalizations, it was extremely low, but the percentage of the tests, I mean, it was still very good. I mean, we're in the 2 to 4 range, but it wasn't all the way at the bottom because we were just getting started and figuring out who needed to be tested and getting enough testing capacity. Then in May, as we got more testing capacity and our case counts went way down, you can see our percent positivity was also extremely low. But as we peaked in the summer with cases, and now as we're reaching new highs, you can see the percent positivity has gone up. And in particular, earlier in November, we actually peaked above 10%. We use the 5% as the cutoff for the green, and then 10% as the cutoff for the red light in terms of whether or not we're providing sufficient testing. But again, it's sort of in the art and science. When we just go above 10 and then come back down, we don't change it right away. We give it a little bit of time to see if it settles out. And as you can see,
And Dr. Johnson, may I interrupt you for a second? Can you explain how to get to this data for folks who are following along and may not be able to see it?
Yes, sorry about that. So this one is actually on the Alaska Health Department. So I will say, I'll just show you how I get to it. If you Google Alaska Health Department and then go to, it comes up as Alaska Department of Health and Human Services. And then the first option is the DHSS COVID-19 website. And then from their website, if you scroll down, you'll see a number of metrics that they report. And there's a link to their Alaska Coronavirus Response Hub. And then that brings you to all of their various dashboards. And the second one down is their testing. Having said that, I just realized you can also get to that from our webpage. And then if you select the Anchorage region, you get the numbers that apply to Anchorage. And I just wanted to go to this one in addition to ours because there are some numbers here that I think are important. Excuse me. Over to the right, you can see the average turnaround time for tests from the different types of testing facilities. So at this point, over the past 14 days, the state testing lab has averaged 2.2 days to turn around tests. The hospital facilities have averaged just under 1 day. And the commercial labs, like some of the labs that Visit Healthcare uses, have also averaged just under 1 day. So fortunately, even though we've seen some delays in data entry for us on the websites, the tests are getting turned around quickly, and the labs contact people with the test results right away. So even if there's a lag again on the reporting on the dashboards, we are getting these positive results to people quickly with information about the need to isolate and let contacts know that they've been exposed. Then there's this chart here, and the one that I was looking at is the borough level positivity. And then there are slider bars at the top, which allows you to expand to see the values on the dots, the daily dots a little bit more. And I am happy to say that we have come down from that high up around 10% positivity in the first part of November. We're now down around 7%. The other thing that I just want to mention, part of why I talked about the time from exposure to when something is reported, is that there is a lag from the time someone's tested until when their results show up on the website. And so the most recent couple of days of testing information and of cases by onset will often be artificially low because we don't have all of those test results back yet. So I tend to look about a week back to see where I think we really are in terms of the test positivity. But looking at this right now, I can see that for the past week, we've been staying just under 7%. So looking at that, I feel like we really have come down from the 10% that we were above in early November. And so this really can stay in a yellow range.
Dr. Johnson, we have a question for you from Mr. Weddleton.
Okay.
Hi, thanks. So on the test positivity, this has confused me over the time because you look at it intuitively, you think, oh gosh, it's 10% or 6 or whatever the trend is, more people must be sick. But what it's explained to us, oh no, we're just not testing enough. And I'm not quite figuring out what to gather from this piece of information.
So I think the important thing to keep in mind, as we've probably, any of us with children have tried to stress with our kids, if you're looking at a percentage, you've got a numerator and a denominator. And so when the percentage goes up, it's important to understand, did it go up because the denominator got smaller, or did it go up because the numerator got bigger? So depending on where you are, you'll see that percent going up for various reasons. And it tends to be a combination of it. If you're doing a lot of testing and you stay at, so let's say, you know, we were staying around 5% test positivity, we're testing, I don't know, 5,000 people a day, and we're staying level. And now we continue to test 5,000 people a day, but our positivity goes up. That's an indication that there really is more virus. There are more people who are sick. At that point, we probably want to be expanding our testing because we're probably not finding all of the cases that are out there. But you could also have the situation where, for some reason, we start not having the ability to test as many as we had been. So instead of testing 5,000 a day, we're only testing 2,000 a day. Well, we probably will start missing more cases then because fewer people will have access to the testing. But the people who are really sick will probably still get tested. So what we'll see is that while we miss some of the cases, we're still going to have a higher denominator. I'm sorry, our denominator will have gotten a lot smaller. Our numerator will have gotten a little bit smaller. And so the percentage will have gotten higher. So at that point, we may not have really had an increase in the number of people who are sick. We may just not be having sufficient testing. And so that would say that we need to be increasing the testing so that we're getting more of the people. Because if there's a constraint on the testing, then the people who are less sick, less motivated to get tested, but maybe still need to get tested, are less likely to. And we're going to miss more cases. The more cases we miss, the more people we have out there who are infectious and may not know it, leading to increased spread of disease. Does that help?
Well, I think a little bit. I think the point is you generally have a self-selecting sample that you're getting because people don't come in randomly. They come in because they think, oh, I might have reason to have COVID. I need to get tested. And I think what you're saying is we get larger and larger number of tests. We get closer to the random sample. And, you know, when we have a random sample, then we can really judge what percent of the population is infected. So at 5,000, we don't really know what that number is to get a random sample. But I think that's what you're suggesting then. So
Right.
I'll let it sink in. Thanks.
Okay. Any other questions?
Thank you. I don't see anyone in the queue right now, Dr. Johnston. I just want to do a time check. We have about 6 minutes until the hour, and there is another meeting, the public safety meeting right after us. And I would like to leave a few minutes for public testimony. So if we could wrap up in the next 3 minutes or so, and we have actually Ms. Allard in the queue with a question. Ms. Allard?
Thank you. I apologize. Dr. Johnston, I guess my question would be, because I'm still trying to wrap my head around, I see, and maybe I'm wrong and you could correct me, but have more people been testing?
So that was the other thing that we can look at is, that's the statewide sheet. Here, let me go into, sorry. So now I've gone back to the MOA roadmap detailed measures. And this is the one that you get to from the stoplight page. And this actually also has the percent positivity. I just find it a little easier to read off the numbers on the state graph. But in addition to that, it's the positive test counts. So this is the actual positive tests. What I'm looking for is the count of Okay, so right now, I was just talking, I'm sorry, rambling. The folks who put these dashboards together are actually working on an update that should go live this week that is showing the actual number of tests. So it's going to show the number of tests that were done the previous day, the previous week, and total. And it will also show that number in a graphical format for each of the different testing sites. So you are correct that it's a little tough to find that information right now. On the state website, you can find, let's see. Okay, sorry, and here on the state website, you can find the total number of tests done each day. But the Muni dashboard will be adding more detail about that. And this is where you can really see the fall off in recent days. Not that there were fewer tests, but we don't have the results back. So from the 30th, we only had 78 results reported yesterday. So again, you need to look back somewhere between 3 and 7 days to see how many tests we're really getting. But we're peaking at about 6,000 tests a day in mid-November. Coming down a little bit since then is also an effect from the holidays.
Thank you. Chair, can I just do 2 quick follow-ups? And then I have a slew of other questions, but I'm going to email them to you, Dr. Johnston.
Okay.
Sure, Ms. Allard. I just want to call attention to the time. We have 3 minutes left, and we're going to need to come back to this data in a subsequent meeting.
Oh, it's okay. I'll just send her the email. Thank you, Chair. Thank Dr. Johnson. I appreciate it.
Sure.
Thank you, Ms. Allard.
I'm sorry.
Oh, Mr. Constant has a question. If it's quick, Mr. Constant.
Yeah, I think it's brief. Thank you. And I apologize if I missed this. So we see a lot of this data, kind of today's information, and I know you just were able to show us some over time. Is it possible to download this information in Excel spreadsheet form to kind of help visualize it in our own ways?
So probably I can, that's something that I would ask, I'll have to ask the people who put the dashboard together. So I mean, they have a whole, there are a ton, I guess there are a ton of different Excel spreadsheets, but if there's specific ones you wanted.
Yeah, I just want to be able to track certain information over time that I can't seem to find a way to get from the chart. So I don't know if your contact is available, but I would be able to send this question.
Thank you, Mr. Constant. And Dr. Johnson, unfortunately, we're going to need to move on and come back to this, I think, as I mentioned, in a subsequent meeting. Thank you very much for this presentation, and to Ms. Harris as well. I'm sorry to cut it off, but we're down to 2 minutes, and we do have that other meeting. So
we actually touched on most of the important ones. So thank you for your time. I really appreciate the interest.
No, thank you. I think we'll come back with some of the questions from Ms. Allard and Mr. Constant and other folks who raised some issues here towards the end. Does anyone have anything to bring up quickly on legislative priorities or budget items? Otherwise, we'll move on to audience participation. I don't see anyone in the chat. Were there any members of the public who wanted to speak?
Hello?
You can, yes, Mr. Haberman?
Yes, I'll be brief. One is, my name is Eugene Carl Haberman, and and many of you know who I am. Number one, you're talking about very important information, and the public's blinded to what you are personally seeing, and the public's not in this meeting. And by the way, the only thing on the website for your committee thing is the agenda. I'm thankful for that, but of all subject to have that situation where the public cannot really see what you're viewing, it's making it very difficult and frustrating. The last thing I'd like to say is this: before the administration went into more restrictive situations on dealing with COVID that went into effect yesterday, which resulted in making it more difficult for people who live in Anchorage, and work in Anchorage. I noted to you all that to recognize the situation as whatever you do in Anchorage, as long as it's a wild, wild west out in the valley, it's going to be very complicated for you to be successful. And it is a wild, wild west out there. I addressed the Borough Assembly last night on this, and plead with them to be more responsible. But remember this, the borough does not have police powers. And because they have no police powers, and the governor is looking the other way. And the borough is not the only place, the Matsu borough is not the only place in Alaska that doesn't have police powers. So even as important as mandates for requirements for mask wearing cannot go because these communities don't have legal authority. So I would also encourage you as representatives to plead with the governor, because your job in trying to deal with COVID is more complicated because our governor is not taking appropriate action to make it more safe for everyone in Alaska dealing with these difficult times. And a footnote, your next meeting that you're having shortly, all you have on the meeting for the public safety is the agenda, and there's nothing else there. And then note, starting at 12 o'clock is the Port Commission meeting, and though the Public Safety Committee meeting you have goes to 12:30, you've got an important Port Commission meeting happening starting at 12. Thank you very much.
Thank you, Mr. Haberman. And with that, we are over time. I'll entertain a motion to adjourn.
So moved.
Thank you, everybody, for joining and your participation. Have a good day.